Hi everyone, my name is Angelina and for our pediatric case study, we'll be presenting on osteogenesis imperfecta. And my group members are Peyton Shalhoub, Sophia Tuason, Kunleo Rachel, Lori Hammond, and Joshua Jubile. Osteogenesis imperfecta, or OI, is a genetic disorder primarily affecting the body's connective tissues, and especially in this case, it's the bones of the body. Now, looking at the anatomy of OI, it affects multiple systems in the body. The bones are the most visibly impacted, and the patients often have fragile long bones, spinal deformities like scoliosis, and a short stature. The teeth can also be weak and discolored due to dentinogenesis imperfecta, and many patients can have a blue-gray tint in the sclera of their eyes, and some even experience early hearing loss from abnormalities in the ear bones. And the joints can be overly flexible in these patients, and the cardiovascular system can show issues like fragile blood vessels or heart valve problems. And these are all related to the defective collagen in these patients. And now looking at the physiology, the root issue here is the abnormal type 1 collagen. And in most cases, there are mutations in the COL1A1 or COL1A2 genes. And they either reduce the amount of collagen or they alter the structure of the collagen. And when the collagen is in poor quality, it weakens the bone matrix in the body. And the body responds to this by increasing the bone turnover. So the osteoblasts in the body, they make more bones, but they're poor in quality. So it perpetuates a cycle of formation of bones of poor quality. And additional gene mutations can happen, which can further disrupt processes like protein folding or extracellular matrix formation, which explains the wide range of severity that we see in these patients.
Hey guys, this is Josh, and for the pathophysiology of osteogenesis imperfecta, we see that it is a genetic disorder involving connective tissues due to an abnormality in the synthesis and processing of type 1 collagen. Now, it's characterized by a heightened susceptibility to fractures and decreases in bone density. 90% of osteogenesis imperfecta patients inherit a genetic defect that results in quantitative and qualitative abnormalities in the molecule of the type 1 collagen. Autosomal dominant forms of the disease are caused by defects in the type 1 collagen, while in autosomal recessive forms, non collagenous protein modifications take place. Now, there's abnormal collagen secretion and decreased collagen type 1 secretion that can lead to insufficient osteoid production in the bones. Histological features of OI or osteogenesis imperfecta include poorly organized bony trabeculae and collagen matrix, scant spongiosa, relative abundance of osteoclasts and osteoblasts, heightened bone turnover, broad irregular physes with disorganized proliferative and hypertrophic zones and thin calcified zones, further contributing to bone density decreases and increased risk for fractures in patients. So, as nursing students trying to be future nurses, a big part of our care is patient education, and the same is true for parents of patients with OI. So, in layman's terms, to explain to them the pathophysiology of osteogenesis imperfecta, we could simply describe it as a inherited connective tissue disorder that causes restricted growth, deformity, and fractures. And that is the best way, in my opinion, for layman's terms of describing the disorder to parents. Thank you.
Hi, this is Rachel. I'll be covering the nursing management of osteogenesis imperfecta. OI is a genetic disorder characterized by fragile bones that break easily, so our nursing care must be extremely gentle and supportive, not just physical but emotionally too. So let's start with assessment. As nurses, we should closely monitor for signs of fractures, bone deformities, or limb shortening. Pain is also a big concern. Some children experience chronic discomfort, while others have acute pain after minimal trauma. We also need to assess for growth delays, especially in more severe types. And don't forget to check respiratory status in children with chest deformities and hearing loss as the child grows older. Lastly, Assessing the child's emotional well-being is essential, as repeated hospitalization or physical limitation can impact the mental health. Now for interventions, first and foremost, handle with extreme care. Even regular activities like turning the children or taking their blood pressure can cause fractures if not done properly. We should work with the physical and occupational therapy to encourage safe mobility, which helps maintain muscle tone and function. Pain management is also key. We typically use acetaminophen or prescribed medications, but avoid long-term NSAID when possible. We also need to monitor surgical site if the child has mental rods or breathing, and reposition frequently to protect the skin integrity and prevent pressure injuries. Moving on to education, this is a major part of the nurse's role. We teach families how to handle and lift their child safely, how to recognize signs of fracture, and how to use mobility aids like wheelchairs or walkers. We also explain the purpose of the bisphosphonate therapy, which helps increase bone density. In some cases, we may recommend genetic counseling to help the family understand the hereditary nature of the condition. And finally, we offer emotional support by connecting them with support groups and mental health resources.
I'm Sophia Tuason, and I will be going over the medical management of osteogenesis imperfecta. First, we'll be going over the pharmacological interventions. Biphosphonates are the cornerstone of this treatment. These medications slow down bone resorption and have been shown to increase bone mineral density, reduce fracture frequency, improve mobility and functional outcomes in children with moderate to severe osteogenesis imperfecta, otherwise known as OI. Calcitonin and teriparatide are less commonly used but may be considered in certain cases, and pain management with NSAIDs or acetaminophen is often required, especially during acute fractures or after surgical interventions. Going on to surgical interventions, there is intramedullary rodding. This is a common orthopedic procedure for children with frequent long bone fractures. There are metal rods are inserted into the long bones to help prevent fractures, correct deformities, and improve structural support and alignment. This surgery can be repeated as the child grows, especially if the rod needs to be lengthened or replaced. Patients can benefit from multidisciplinary approach, such as orthopedic surgeons, endocrinologists, physical therapists, and genetic counselors. This collaboration helps ensure that comprehensive care, especially for managing both health, mobility, and developmental delays. Next, we will be going on to nutrition and supplementation. Adequate calcium and vitamin D intake are essential to support bone health. Nutritional counseling helps ensure children meet daily requirements to support growth and development. Lastly, physical and occupational therapy helps maintain muscle strength and joint flexibility. This therapy also assists with safe movement techniques to prevent injury and helps enhance independence in daily activities.
Hi, so in this slide, we will be discussing the growth and development and Erickson stages of psychosocial development for individuals who have osteogenesis imperfecta. So the first stage is trust versus mistrust, and this is from infancy, birth to 1 years of age. So children who have OI, they can experience disruptions in inconsistent care due to frequent hospitalizations and prevailing pain that might affect the child's ability to establish a strong bond to their parents and interrupt the development of secure attachment. The insufficient care experiences with their parents can interfere with the developing of a trusting bond. So the next stage is autonomy versus shame and doubt. This is experienced during toddlerhood from 1 to 3 years of age. And in this stage, the patient with OI, they have limited or impaired mobility or need for gentle handling due to their medical condition. This can impede their ability to explore their environment and develop independence. Overprotective parents can hinder their child's drive for autonomy, and this can lead to self-doubt in the child. The parents are wanting to protect their child from possibly being injured again, because they do, depending on their degree of OI, they can fracture really easily. So out of protection for them, they can actually end up hindering this important developmental stage of their child to be able to learn how to be autonomous for themselves. Now, the next phase is initiative versus guilt, and this is experienced during the preschool age, from 3 to 6 years of age. So the child with OI, they may have physical limitations that might restrict them from participating in games or activities with their peers. So this may lead to feelings of guilt or inadequacy, and the need for adaptations or accommodations in the play setting. It can create a sense of being different and hinder the child's initiative. They don't want to be seen as different, so instead they may go ahead and choose to just sit back and watch and observe, which makes it so they're not participating the way they should be at this age level and learning how to take that initiative. So the next stage is industry versus inferiority. This is for school age kids from 6 to 12 years of age. And kids who have OI, they may have frequent absences from school due to needing to, be inpatient in the hospital or doctor's appointments or being at home because of pain or, limitations that are just keeping them from attending school on a regular basis. And this can interfere with their academic progress, and it can also cause problems with their feelings of their competence in their school abilities. So these physical differences and limitations in extracurricular activities can also lead to feelings of inferiority and struggles with acceptance from their peers. So the last stage in the childhood development for Erikson stages is the identity versus role confusion. Now, this is experienced for adolescents from the ages of 12 to 18. And during this time, their body image, they may have body image concerns related to their stature. It's common for OI patients to have short stature. They may have bone deformities due to their multiple fractures and the healing of them, and multiple scars as a result of all of these fractures and possible surgeries and just injuries that they've acquired over the years. And all of these issues here can go ahead and impact the patient's self-esteem and impair their identity formation. So they can also have limited participation in teenage activities that can hinder a real strong sense of self and social belonging that's really important for our adolescents to develop during this age between 12 and 18. So living with OI, it presents a lot of challenges and difficulties for for these kids who have this disease and are trying to progress at a psychosocial developmental rate like regular kids that are healthy and don't have any impairments. And these kids with OI can really struggle with hitting these milestones of development.
So I'm going to address psychosocial and family impacts that OI can have. Living with OI places a heavy emotional and psychological burden on both the child and the family. Parents often live in a state of constant vigilance, fear, and emotional exhaustion due to the unpredictability of fractures and emergency care needs. Children with OI may struggle with low self esteem, anxiety, and poor body image, especially as they become more aware of how their condition affects their appearance and mobility. Many experience visible craniofacial differences that can impact social confidence and peer relationships. Family life is deeply affected. OI can place a significant burden on family relationships, sibling roles, and parents' emotional health. Social isolation is also common as caregivers may limit the child's activities out of the fear of injury, which can lead to isolation for both the child and their family. In many cases, parents take on demanding caregiving roles. One study describes how parents often feel like they are acting as full-time nurses or therapists, which can lead to burnout and role overload.
Our question for our classmates is, what suggestions can the nurse provide to the patient to encourage independence and daily self-care while they are healing from an upper body or a lower body bone fracture?